Have you ever wondered why patients with IBS can have severe symptoms, yet completely normal blood tests, colonoscopies, and imaging? I'm Dr. Nushin, and today we are going to make sense of IBS by understanding its underlying mechanisms. Once you understand those mechanisms, everything else, including risk factors, diagnostic tests, symptoms and signs, and treatments will click into place for you. IBS isn't complicated, but most people learn it backwards. So let's fix that. Picture this, a 28-year-old woman. She's been dealing with abdominal pain for years. Daily bloating. She plans every outing around where the nearest bathroom is. Not because she is anxious, because she has to. Every test she has had, normal. Blood work, colonoscopy, imaging, all of it comes back clean. So, what's actually going on? I am Dr. Nushin, and in this video, we are going to answer exactly that question. By the end, you'll understand what's driving her symptoms, why the tests look normal, and why her pain is absolutely real. We are going to break down the 7 pathophysiologic mechanisms of IBS, the way they actually connect and build on each other. Let's get into this. What is IBS? This patient has IBS, Irritable Bowel Syndrome. Let's briefly unpack that name because it actually tells you a lot. Irritable bowel. The bowel is genuinely more sensitive and reactive than it should be. Think of it like an overly reactive person who gets upset over small things. The gut gets angry at ordinary stimuli that wouldn't bother a normal gut at all. Syndrome. There's no single lesion, no ulcer, no structural damage you can point to. It's a disorder of gut-brain interaction, a system-level problem, not a local one. We'll come back to this when we talk about the brain-gut axis, and this is exactly why tests look normal. But the symptoms are real and often genuinely disabling. Mechanism number 1, visceral hypersensitivity. This is the most important mechanism. Everything else kind of feeds into this one. Simply put, the internal organs, specifically the intestines, are abnormally oversensitive. The gut's alarm system is turned way up. Stimuli that would normally go unnoticed cause real pain. To understand why, we need to look at how the gut sensory system normally works. The gut wall has sensory nerve fibers embedded in its lining, its muscle layers, and its own nervous system, the enteric nervous system. These fibers detect 2 things: mechanical stretch, or how full or distended the gut is, and chemical signals, what is in the lumen. Then they relay this information locally to coordinate gut movement. And they also send signals up to the brain and the spinal cord via the vagus nerve and the spinal pathways. There are specific sensory cells involved here, enterochromaffin cells. They detect chemicals in the gut, nutrients, microbial metabolites, inflammatory signals, and respond by releasing serotonin locally. That serotonin then stimulates nearby nerve endings to fire and send signals upward. Serotonin here acts like a whistleblower. It announces what's happening. There are also tuft cells, which act like sentinels, specifically watching for signs of infection. When they detect a threat, they release acetylcholine, which is more like a motor command, telling the gut to squeeze, move, and secrete. The enteric nervous system handles local reflexes, but when something bigger needs coordinating, like the timing of defecation or appetite signals, the gut reports to the CNS. The parasympathetic system, via the vagus nerve, boosts gut activity. The sympathetic system dials it down. Together, they fine-tune what the gut does based on what the body needs. Now, in IBS, this entire sensory system becomes dysregulated, and it happens at two levels. At the peripheral level, the nerve endings in the gut wall become hyperreactive, their firing threshold drops, inflammatory mediators like prostaglandins and histamine phosphorylate ion channels, making them open more easily. Nerve growth factor upregulates the number of sensitizing channels on cells, so nerves fire at lower stimuli. On top of that, there are silent pain receptors that are normally dormant. They require very strong stimuli to activate. In IBS, inflammation wakes them up, and once they are active, they lower the response threshold further. So you end up with hyperalgesia, where painful stimuli feel even more painful, and allodynia, where things that shouldn't be painful are, like gas or a mild contraction. Think of it like sunburn to skin. Even a light touch on this skin becomes unbearable. At the central level, in the spinal cord and brain, the amplification continues. In the dorsal horn of the spinal cord, where peripheral signals are processed, neurons become hyperexcitable, partly from sustained input coming up from the gut and partly from neural plasticity. The neurons literally learn to fire more easily, just like neurons do during learning. Substance P gets upregulated. NMDA receptors become more active, and glial cells get involved. And at the brain level, the processing of gut signals becomes abnormally amplified. Regions like the thalamus, insula, anterior cingulate cortex, and prefrontal cortex all show greater activity in IBS patients. The brain starts to treat gut sensations as threats, even when there are none. It develops predictive responses, hypervigilance. It constantly scans for signals from the gut and interprets them as dangerous. This is actually an evolutionary safety mechanism, but in IBS, it goes into overdrive. The result? A gut that is genuinely hurting from signals that shouldn't be causing pain. Mechanism number 2, abnormal gut motility. Motility, the coordinated muscle contractions that move food and stool through the intestines, is disrupted in IBS. It can be too fast, too slow, or just completely irregular. Normal motility has a few key features worth knowing. Transit time from mouth to exit is 14 to 58 hours. Contractions are smooth and coordinated. There is a normal temporary increase in colonic activity after eating, called the gastrocolic reflex, and a mild response to stress. Bowel habits are regular and predictable. We need this regularity for proper water absorption, which gives you a formed soft stool, smooth passage without spasms, and complete evacuation. 3 systems control this: the enteric nervous system, the autonomic nervous system, and a set of hormones and chemical signals. The ENS, we have established this is the brain of the gut, has 2 main nerve networks: the myenteric plexus, which sits between the muscle layers and controls contractions, and the submucosal plexus, which sits closer to the inner lining and controls secretion. Acetylcholine triggers muscle contraction. Nitric oxide and the VIP trigger relaxation. These reflexes create the wave-like peristalsis that moves food forward. The autonomic nervous system modulates the pace. Parasympathetic dominates during eating, more acetylcholine, more contractions. Sympathetic dominates under stress. Noradrenaline suppresses enteric activity and slows things down. When these two are balanced, everything runs smoothly. In IBS, particularly under chronic stress, the sympathetic system ends up in a persistent overdrive, and the balance breaks. Now the chemical side. The GI tract is actually a neuroendocrine organ. It produces serotonin, gastrin, CCK, motilin, VIP, ghrelin, neuropeptide Y, somatostatin. All of these work in a precise, coordinated sequence. Before eating, ghrelin rises and prepares the stomach. After eating, gastrin and CCK kick in. Serotonin triggers peristalsis, and then neuropeptide Y slows things for absorption. This is the normal flow. In IBS, this chemical orchestra is out of tune. Too much VIP causes excess secretion and speeds things up. Too much CCK slows the stomach abnormally. Reduced neuropeptide Y makes transit faster. Excess serotonin makes nerves overfire and contractions go haywire. And in women especially, fluctuating estrogen and progesterone during the menstrual cycle can directly affect smooth muscle and pain threshold, which is why IBS symptoms are often worse around menstruation. The bottom line, motility in IBS is unpredictable because all three control systems are dysregulated simultaneously. Mechanism number 3. Intestinal barrier dysfunction. The intestinal barrier is a single layer of cells that acts as a gatekeeper between the gut contents and the rest of your body. When it's working normally, it absorbs nutrients and keeps everything else out. When it's dysfunctional, it becomes leaky, and things that shouldn't cross over do. There are 3 layers of defense here. The biological layer sits on top of the epithelium. It's made of mucus, antimicrobial peptides, secretory IgA, and beneficial bacteria. The mucus physically traps particles. The peptides and IgA neutralize threats. The healthy bacteria secrete short-chain fatty acids that maintain the integrity of the junctions below. In IBS, mucus quality changes, peptide and IgA levels shift, and this first line of defense weakens. The immune layer is the gut's local security force. In a healthy gut, it tolerates food, ignores helpful microbes, and only responds to real threats. In IBS, it becomes hair trigger sensitive. More immune cells accumulate in the mucosa, more mediators are released. Mast cells are particularly important here because they sit right next to enteric nerves. When they activate, their products directly sensitize those nerves. T cells maintain a mild but persistent inflammatory state. This isn't dramatic inflammation, but it's enough to keep the system on edge. The epithelial layer is the physical wall. Cells held together by tight junctions, adherens junctions, and desmosomes. Substances cross either through the cells, called transcellular, or between them, paracellular. In IBS, the proteins that make up these junctions are expressed in lower amounts, and the actin cytoskeleton that stabilizes the cells changes, making both routes easier to pass through. So gut contents reach the tissue underneath, trigger that mild immune response, and sensitize the nerves sitting there. Leaky gut in IBS is not catastrophic, but it creates a steady stream of micro-triggers that keep the immune system and nervous system activated. Mechanism number 4. Altered gut microbiome. The gut microbiome, the community of microbes that normally live in your intestines, is shifted in IBS. This is called dysbiosis. The composition changes, the diversity decreases, and the function changes with it. In a healthy gut, the microbiome does 4 things. It feeds, breaking down complex carbohydrates and fibers that our own enzymes can't handle, and producing useful metabolites like short-chain fatty acids. It protects, competing with harmful microbes for space and nutrients, and supporting the barrier. It trains, educating the immune system to tolerate helpful bacteria and food signals while staying ready for real threats. And it communicates, sending signals to the brain through metabolites, nerves, and immune pathways. Dysbiosis disrupts all four. When microbiome composition shifts, fermentation patterns change. Undigested material that makes it to the colon gets rapidly fermented, drawing in water, producing gas, and in some cases, excess methane production that slows transit. The gut reacts more strongly to these altered food microbe interactions. The metabolite output changes too. Fewer short-chain fatty acids means less nourishment for the colon lining, less support for tight junctions, and less regulation of inflammation and gut-brain signaling. The gut's internal maintenance system gets less reliable. With fewer healthy bacteria competing for space, harmful microbes can colonize more easily. Their products cross the weakened barrier and trigger immune activation, which leads to the next mechanism, and the immune training component breaks down. Without the normal signals from a healthy microbiome, particularly butyrate and propionate, the immune system doesn't get coached properly. It starts misreading harmless bacteria as threats. That immune oversensitivity is a direct contributor to the low-grade inflammation we see in IBS. The microbiome change is both a cause and an amplifier. It sets off a chain reaction that touches every other mechanism we have discussed. Mechanism number 5, disturbances in the brain-gut axis. This one ties everything together. The gut and the brain are in constant two-way communication via nerves, hormones, immune signals, and microbial metabolites. In IBS, that communication becomes distorted. Think of it as a text chain between the gut and the brain. The brain sends instructions that regulate digestion. The gut sends back sensory updates, stretch, chemical content, irritation. The brain adjusts motility, enzyme release, blood flow, and appetite accordingly. When the exchange is clean and calibrated, everything works. In IBS, the messages are garbled. These are 4 communication pathways in this axis. The nerve pathway. Sensory signals travel gut to brain. Control signals travel brain to gut. The vagus nerve and ENS carry most of this traffic. In IBS, the sensory signals coming up from the gut are louder and noisier than they should be. The brain reads normal gut activity as painful, and the autonomic balance shifts towards stress mode signaling instead of rest and digest. The hormonal and neurotransmitter pathway. Serotonin, CRF, cortisol, dopamine, GABA, CCK, Motility, they all participate in fine-tuning the conversation. In IBS, this panel is poorly synchronized. The HPA axis, the body's stress response system, becomes overactivated. CRF and cortisol make the gut more reactive, more permeable, and more sensitive. This is useful in genuine danger. But in IBS, it keeps the gut stuck in high alert even when nothing is wrong. The immune signaling pathway. The low-grade immune activation we talked about sends cytokines upward to the brain. The brain responds by paying more attention to gut sensations, increasing the stress sensitivity and intensifying the symptom experience. The brain isn't imagining anything, it is responding to amplified danger signals from below. The microbial metabolite pathway. Short-chain fatty acids, bile acid metabolites, and tryptophan-derived molecules all communicate with the brain through ENS, vagal pathways, and sensory nerves. When dysbiosis alters what gets produced, the brain receives a different and more distressing set of signals. Tryptophan metabolites affect serotonin signaling and immune activity. Bile acid metabolites affect transit speed. Short-chain fatty acids regulate inflammation and barrier stability. When these shift, everything from motility to mood can change. The overall picture in IBS: brain to gut, stress and emotional state directly worsen digestion. Gut to brain, abnormal bowel activity sends stronger distress signals. The loop reinforces itself. Mechanism number 6. Low-grade immune activation. We have referenced this several times now, so let's focus on it directly. The immune system in IBS is not silent, but it's also not overtly inflamed. There are no ulcers, no erosions, no tissue destruction, nothing that would show up on a colonoscopy. This is different from IBD. What's happening in IBS is subtle, a slight but persistent immune activation that doesn't cross the threshold into visible disease. In a healthy gut, the immune system is always active. It constantly samples bacteria and food particles and decides what to ignore and what to respond to. That's normal. It's tightly controlled and self-limiting. Anti-inflammatory signals keep responses proportional. In IBS, this threshold shifts. The decision to react gets triggered more easily. Mast cells accumulate near enteric nerves and release mediators, histamine, cytokines, proteases that directly sensitize those nerves. T-cell populations shift. Low-level increases in pro-inflammatory cytokines like interleukin-1 beta and TNF-alpha can be detected. Not dramatically elevated, but enough to keep the system primed. This immune activation sensitizes nerve fibers, alters motility, contributes to barrier dysfunction, and sends signals up to the brain. It's not the cause of IBS, but it amplifies every other mechanism that's already running. Mechanism number 7. Bile acid dysregulation. Last one. And it's particularly relevant in IBS-D, the diarrhea predominant subtype. Normally, here is how bile acids work. The liver produces them from cholesterol. The gallbladder stores them and releases them after a meal when fat enters the small intestine. They break down fat droplets so digestive enzymes can work on them. Then, in the terminal ileum, about 95% of bile acids are reabsorbed and sent back to the liver via the portal circulation. This is called the enterohepatic circulation. Only a small amount makes it to the colon, where bacteria convert them into secondary bile acids that support normal bowel movements. When too much bile acid escapes reabsorption and reaches the colon, it pulls water into the lumen and speeds up colonic movement. This is essentially secretory diarrhea triggered by bile acids. In IBS, the problem is in the regulation loop. Normally, after reabsorption, the ileum sends a signal called FGF19 back to the liver telling it to slow down bile acid production. In IBS, this signal is too weak. So the liver keeps making bile acids at a normal or even higher rate. More spills into the colon than should, and the colon responds by secreting water and accelerating transit. The liver itself isn't damaged, the regulation is broken, and the result is watery urgent bowel movements. Exactly what you'd expect from bile acid overload in the colon. So that's all 7 mechanisms: visceral hypersensitivity, abnormal gut motility, intestinal barrier dysfunction, altered microbiome, brain-gut axis disturbances, low-grade immune activation, and bile acid dysregulation. None of these happen in isolation. They feed into each other, amplify each other, and together produce a gut that is genuinely in distress, even when every standard test comes back normal. That's the key insight here. Normal tests don't mean there's nothing wrong. It means the problem is in the system, not in the structure. If you found this useful, subscribe, because we are going to keep breaking down exactly this kind of pathophysiology, mechanism by mechanism. And if there is a topic you want covered, drop it in the comments. See you in the next one. So you have just built a foundation for understanding IBS. In the next video, we will connect the risk factors to these underlying mechanisms, and we will explore why some people develop IBS in the first place. So if you want to truly master medicine, not just memorize it, subscribe, and I'll see you in the next video.